Hello. I would like to also pay my respects to the traditional owners of this land and to their elders past, present and emerging, and just wanted to also give you a shout out for those of you who are listening to podcasts. Mamma Mia has an amazing podcast with young female Indigenous people and listening to their stories if you wanted to check that out. So I am a mixed methods researcher at the School of Public Health and Preventive Medicine at Monash University, and I'm just going to present to you some of the research we have done talking to older people. But I wanted to first start with this. Up, the movie, came out in 2009, and it's one of my favourite movies. And I remember when I was watching it, I hadn't started this research area at all. I just started my PhD, but one of the things that struck me about the movie Up was this is Carl. He's an old person. And Carl basically got ambushed by a little wilderness scout called Russell, who needed to earn a badge for assisting the elderly. And for those of you who've seen the movie, did Carl want assistance? No. And so that was something that really did stay with me as someone who I wouldn't put myself in an older person category yet, but as a younger person thinking, am I one of those people who are trying to give assistance in ways that may not necessarily be perceived as helpful? Am I designing things? Am I advocating for things for an older person which may not actually be what they want? And so a lot of my research is actually about asking older people, what do they want? And trying to understand where they're coming from. So I'm going to present some of that information. But first, I wanted to talk to you about falls prevention, because that's one of the main key areas of research that I do. So what is falls prevention? Anyone? Preventing falls. Don't you think it's a weird term to put out there? Particularly to people who may not work in health? Because what does falls prevention comprise of? Does anyone know? Strength and balance, exercise, education, information, yes. Oh, decluttering, yes. Yep, I do that with my parents all the time. Decluttering, yep. Risk assessments. Podiatry, anything else? Medication, optometry. Can you see it's actually quite big? Yeah? So this term falls prevention, strength and balance and exercise is a part of it, and that's what we're going to probably focus on today. But just being aware that when we use this terminology in practice, it actually means a lot. There's a lot in there. It's not an easy to understand aspect, and I don't have enough time to talk to you about health literacy, but health literacy is also a very important thing to kind of keep in your mind when you're thinking about working with community. So I am not a clinician, but I was trained in first biomedical science, then public health, in particular with health promotion. I did my PhD with Ben Smith. And we are very much trained in a risk paradigm. Okay, so when I was studying, it was all about you need to do this to prevent death. You need to do this to prevent injury. You need to do this to prevent X, Y, and Z. That's great, except that the general community doesn't think in a risk paradigm. Okay, we're trained in it, and so we then think we need to communicate in those messages, but the general community prefer positive messages. And so while we might be saying, as it says up here, don't eat candy or you'll get fat, the general public are going to respond better to a message of eat fruit and be slim. Same concept, different message. Yeah? So message framing is really, really important and something that we need to keep aware when we're trying to engage with people. And so I really think the power of the positive message needs to be harnessed when we're trying to communicate strategies of aging well and improving our well-being. And so, think about it from your own perspective. Would you rather have a 10% chance of mortality or a 90% chance of survival? And I think something we need to be really conscious about is that we, particularly from health promotion, public health, health services, we have gone with the fear message because we think if people are scared, they'll do something. And from my cultural background, we thrive on the fear message. I'm Sri Lankan. I grew up, my mum told me my whole life that I was going to die. My whole life. Don't go out, Dash, you are going to die. Don't go in the cold, you're going to get a cold and die. And so that, we came from that very risk message. But when you're raising awareness, you want to raise awareness, not alarm. Because sometimes when you raise too much alarm, people shut down and they stop listening. And we can see that in the TAC ads. You can see that they've gone from showing you the diseased lungs and the all of that gunky stuff from your arteries to kind of saying, this is what you will gain if you stop smoking. Your hair will look better, your eyes will look brighter, you won't stink. That kind of message is about what you're going to benefit, as opposed to if you keep doing this, this is what you're going to lose. It was very interesting. I was at a public health conference recently and they were talking about how Kraft had put out, I think it was macaroni and cheese, and they had put the boxes out and it said reduced salt, and their sales went down. No one wanted to buy the reduced salt. And so they rebranded and repackaged with just a hint of salt, and it went back up again. So the power of that message is really, really important. So I'm going to talk to you about a few different studies that we have been involved in. And the first one I want to talk to you about is Personal Alert Victoria. Alex Natura is sitting here. She also worked on this project with us, and it was fascinating. So funded by the Victorian Department of Health and Human Services. And it was very much looking at this service, $10 million in Victoria, and it provides personal monitoring and emergency response service to older people to support older people to live in their homes for longer, okay? So it's like a safety net. It fosters confidence and safety because they're able to alert someone if something happened, okay, by pressing this button. Now, falls are a problem in this client group. They're frail people. They have medical conditions. So recent falls or perceived falls, risk of falls, was a reason for people to come onto this service. And falls was one of the most common reasons that someone had activated their alarm. So 45% were due to falls and 20% were due to being unwell, which was this kind of category we weren't quite sure how to make sense of, but they could have fainted. They could have had some kind of issue which led to a fall, but it wasn't necessarily coded as a fall. So we did, and there was a lot around this project. I'm only going to report to you on the 12 interviews that we initially did to help inform this work with Personal Alert Victoria clients. And so this is Darsh in her first project around falls prevention. This is my interview question. Tell me about your fall. And none of them, or most of them, did not respond using the word fall. Okay, so listen to this. I tripped over. Landed on my knees, scuffed my knee a little bit both times. Silly things where I've tripped. I slipped. I went flying. Shaking. I find myself on the floor or the ground. I was in the shower and I slipped. I tripped into the house and I slipped. So I interviewed 12 people. That's quite a few responses that I'm presenting to you already, and they're not using the word fall. Okay, when I've specifically asked them to tell me about their fall, they have avoided that word. So that's one thing to think about in terms of terminology around your programs. So then I asked them specifically, what do you think about falls prevention? You know, how much are you engaging in? And as we kind of pointed out at the start, falls prevention is a term pretty hard to understand. You ask someone, oh, are you involved in falls prevention activities? They're like, huh? I think I do a lot of exercises here without going to the physio. I love this guy who's 84, telling me all about he flexes his muscles in front of the mirror every morning to loosen up. I do a fair bit of exercise myself. I love that both of these quotes are from men who think they have this under control, okay? They're doing the exercises themselves, it's all fine. Then I asked, do you think you're at more risk of falls? And one of the participants said, well, I hope not. I haven't had any for a while, okay? I've got a walker, and if I go on a long walks because I get a little bit wobbly, I take the walker. But otherwise, I seem to be walking okay. So they're using a walker. They've said they're a bit wobbly, but they don't think they're at risk of falls because they're using the walker. And then another participant said, I hear on television a few people falling down and I'm careful how much I can do, but if I fall, I fall. Couldn't say nothing. Couldn't say, that can't happen to me, it happens to others, it can happen to me too. And then also this concept of the truth is, I can't believe that I'm old. Yeah? So what's our take home from that? Older, frail people do not use the word fall. So if we're trying to communicate with them to get them engaged in falls prevention activities, don't think we should use it either. And they do not think falls prevention is relevant to them. Either they think they're doing activities that are falls preventing already, or they think you're not actually going to be able to prevent falls for me. I'm old, I'm frail. This is just part of life, okay? Study 2, this was funded by Arthritis Australia. This is a recent study that we've been doing, which is falls and falls prevention among people with osteoarthritis. And we did semi-structured interviews with 20 people, around 65 years of age, majority were female, and 10 had experienced a fall in the previous 12 months, okay? So, ask the question, do you think your OA causes falls? And a bit mixed. Some said yes, some said no. Quite a few kind of said, no, I'm more likely to have a fall because I'm running around, it's not because of my osteoarthritis. I know people who have tripped over, plenty have fallen over without having osteoarthritis. Okay, so that's an interesting thing to think about. Then I asked them about falls prevention activities. And again, this just really highlights how little there is around the literacy around this. I guess it would be strengthening exercise, would it? I don't know. There's a lot of signs around town about things like Pilates and yoga and so on, but to prevention exactly, no. And I suppose the immediate thing that comes to mind is a walking stick. Now, I don't know about you, but if I'm sitting there thinking, oh, I'm being told I need to engage in falls prevention and that means that I need to have a walking stick, I don't think I'll be putting my hand up for that. And so, you know, understanding how they perceive this is really important, because if they're only thinking about falls prevention as being using walkers or canes, they may be reluctant to disclose falls in the first place. And then this, sometimes I go to exercise where they do more harm than good. And I have to say, look, I already do Tai Chi twice a week and Pilates, but I'm a bit cautious because I've had a few injuries from it. I had to keep saying, I'm old, I can't do that. And so it's interesting, you know, talking about the recommendations for physical activity for the older person, and I'm not doing them, right, as a younger person. And I think about my mum, and there's no way she would be putting her hand up to be doing some of those more high-intensity exercises. And, you know, this is reflected in some of the quotes that we've been hearing from our participants. So then we asked them actually specifically around the terminology of falls prevention, because one of our endpoints for this study is to actually develop up resources. And so we wanted to really know, what do they need to know, what should we include? And I love this. Having a fall is something older people do. Falling it over is something that active people do. True? Yeah? Finding a different name for it to start with to attract somebody in my age bracket. So if we're thinking some of these prevention efforts and getting people physically active, doing strength and balance needs to happen in midlife. And so if we want to attract people in that midlife age bracket, we can't be badging it as falls prevention, which has connotations with being old and frail and a walking stick. To me, falls prevention sounds very negative. I don't seem to fit in that category, even though I've had, 100 falls probably. And I hope it sounds more fun. And we heard before about the importance of fun than falls prevention. If you're trying to sell a program or provide a program to be sold, it needs a good marketing image. Yes, I think so. And so one of the take-homes from that is, even if your older person has health conditions that could increase their risk of falls, because that's how I think, risk of falls, they may not consider themselves at risk of falls, even if they've had falls, okay? So in terms of like tailoring and targeting your communication, don't just think because they've had falls, they have a health condition that, increases their risk of falls, that they're going to automatically think that they're at risk of falls. It's not linear. So then our final study that I wanted to talk to you about is Respond. And Respond was funded by the NHMRC, led by Associate Professor Anna Barker. And the catch cry of Respond was to respond to the first fall to prevent the second. So it's actually secondary prevention program. And what happened is that we recruited people who presented to the emergency department with a fall. Okay, so they had a fall that was bad enough that they had to go to the emergency department and be assessed and seen. And basically, once they were discharged home, they had a home-based risk factor assessment. They had education on risk factor management, goal setting, coaching, follow-up telephone interview support, and healthcare provider communication. So we had trained health coaches who were trained in positive health messaging, motivational interviewing, who contacted our intervention participants on a regular basis around goal setting, but also linking them into the community so that they knew what was already out there. It wasn't about reinventing the wheel. Our intervention wasn't about designing all of these programs. It was actually facilitating access to them. And the program targeted 4 risk factors that were evidence-based in terms of increasing risk of falls. And so poor balance and loss of strength, vision impairment, poor bone health, and long-time use of benzos. And alongside the randomised controlled trial, we had a program evaluation, which is amazing because you can see whether or not you delivered as planned, but also what do people think in terms of acceptability of your intervention. So we had a survey of 225 intervention participants, and then we also had qualitative information from focus groups with 41 participants. This was what our Respond modules looked like, and they were co-designed. And our catch cry was be your best. And so it was all about positive health messages, healthy aging. It was a focus on wellness and not on falls. So nowhere on those pamphlets is the word falls, okay? So it's be your best, better strength and balance. Be your best, better bones. Be your best, better eyesight. Be your best, better quality sleep, okay? It's not, hey, we need to prevent falls and you need to improve your strength and balance. And so in the focus groups, what they told us is, oh, they look happy. These people look happy in these pamphlets. They don't look sad and unwell and frail. There's nothing in there to say you've had a fall. It's just be your best. And it's health education. I think it's excellent. And then from one of our health coaches and clinicians who are delivering it, I think it's good, especially for the patients who are very fall phobic. It was a patient-centred approach. So it was about listening to the person and tailoring our messages and our intervention activities and our goals based on what they wanted to do. And it was really interesting because a lot of them said, I don't actually react well when people tell me what to do. I think I would know best. And the types of phrases that stuck in their minds in terms of what the clinicians had said to them is, what would you like to have a go at? What's something that you might be interested in? What exercises do you like? What would you like to do? And one of the interesting things is they would often say, I don't want to go to one of those gyms. They're really scary. And I don't know, but I will go and do an exercise class where there's a cup of tea and scones afterwards, because that also facilitated social support and connection in their community. And so it was around listening to that and connecting them in with those types of services. And this is just a quote from one of the Respond clinicians as part of the program evaluation. They said, when people set their own goals, it's a lot more empowering and they're a lot more motivated to actually do them because they've come up with it themselves. They feel like they can achieve it. Okay, so if I'm saying to an older person, you need to do 150 minutes of exercise, moderate intensity every single week, they didn't come up with that. They might be daunted by that. They might be sitting there going, I can't do that. But if you were to work with them and identify a goal that they would like to achieve, and yes, in your mind as a clinician, you might be sitting there thinking, I want to get them to this point, but work with them with where they're at, set the goals that they want to be achieving and keep moving them forward. This is one of my favourite little clips, and some of you may have seen that. But this, I think, is to the power of empowering, and I think we need to really sit there and say, hey, let them dance.
No more.
here are just some references for you if you want to read a little bit further about the work that we have been doing, but you can also follow me on Twitter. And I just wanted to do 2 plugs. Monash University has a Fitness Australia accredited exercise course that we do in how to optimise strength and balance for older people, and it is all around what kind of exercises do we need to be doing with older people, but also positive health messaging. And so you can look that up on the School of Public Health and Preventive Medicine website. We're running that again later towards the year. And also Danielle Berkovic and myself are running a workshop today, and if you want to really learn how do you actually create some positive messaging, we've got case studies to take you through, and you can have a little bit of a brainstorm. So thank you.